Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello everyone, I'm the Millennial Mechanical Therapist, and this is part 2 of why MDT is safe for all clinicians. In part 1, we spoke upon a good history taking and finding those red flags, the use of classifying patients in mechanical syndromes versus pathoanatomical diagnoses, and today we're starting upon force progressions and force alternatives. So a force progression is simply adding forces, as it sounds, going from patient-generated all the way up to therapist-generated mobilizations and manipulations. And a force alternative would be changing positions or taking gravity out of the situation so that the patient has a more favorable response. In order to understand this, you kind of have to understand the pain mechanisms in which MDT teaches its certified clinicians, those who take its courses, and their diplomats. And this all goes simply through the traffic light analogy. Green light would mean the patient does a movement, the movement feels good, and it feels good afterwards. That's a green. The next is yellow. Patient does a movement, there may be discomfort during, they may produce pain during, but after the movement, or within about 5 to 10 minutes, there's no pain, or that situation did not linger. And to ultimately red, which is where you don't want to be in any situation, where you do the patient performs a movement or a technique and it produces pain, and that pain stays or increases and stays worse for longer than 5 to 15 minutes. You have to understand that to understand what I'm about to say. So, if you're doing a force progression, the patient performs a movement, let's just say to keep it simple, they perform extension in line. And it's decreasing their symptoms but not abolishing. If they add more repetitions, that's more force. If they feel better from that, that was a green light. If it's produced no worse, that's yellow light. A yellow light would signal you as the therapist to add more force. So you're adding more force, let's say through clinician overpressures or mobilizations, and it gets better. Great, keep going. Or it decreases, but they're no better. It decreases during the addition, but they're not getting better, therefore, afterwards. And this is just trying to keep it nice and simple and keeping us on the ball. If you follow these force progressions, by the time you would get to a manipulation, by the time that you would want to manipulate an individual, you should know how they react to end range forces through a whole bunch of repetitions from them, through mobilizations from you. You should know how they're going to react to an end range force before you apply an end range manipulation or any manipulation. Vice versa, if you're with the individual and they can't handle mid-range forces, then to manipulate that individual would be a horrible idea. And for me, as a clinician, this was huge. A lot of the pre-manipulative testing out there, a lot of the diagnostic imaging through blood flow studies really doesn't support anything of a pre-manipulative test or even signs and symptoms. A lot of signs and symptoms aren't even correlated with a vertebral basilar insufficiency or anything like that before manipulation. So if all these tests are horrible, you have to have something before you apply manipulation. And the progression of forces keeps it safe for us, because we know if I mobilize and they get better, then a few of these keep showing me they're getting better from mobilizations. Well, a manipulation might do well. So the force progressions really help us be safe in applying our forces, as well as applying patient forces throughout their own day. So force progressions can be huge. Another interesting fact is through the same traffic light system, if you find that the individual does not have an arthrogenic or joint-related situation, and it's more myogenic, the new research out by Alfredson about eccentric training really has shown us that yellow light that Mackenzie speaks upon, or the produced no worse is really what it takes for a lot of tendinopathy training or tendon training and eccentric training. They've found that through the best protocols, through the best exercise, really you need to produce symptoms but not have the patient be worse afterwards. And they'll keep producing symptoms until finally that load no longer is problematic. And then they increase the load and continue thereon after. So to recap, force progressions and force alternatives help you know how much force the individual can do themselves, how much force you as the clinician can apply to them, in what directions, and it makes your technique safer, it makes their exercises safer, and it also, in some circumstances, like with a tendinopathy or what MDT would call a contractile dysfunction, your specific loading of that tissue is most appropriate. So force progressions and force alternatives can be huge in allowing you to be safe with your patients, in allowing you to be, providing the right types of work with your patients, right types of exercises and manual therapy. So I hope this clarified some stuff up on why MDT is safe. MDT is wonderful, for any clinician, especially the new grad who really wants to be as safe as they can be with all their new patients' symptoms and signs that they've never seen. It allows you, through history taking, classification, and force progressions and alternatives, to be as specific as you can be and as safe as you can be. And ultimately, that's what we should be doing for any patient that walks in our door, regardless of seeing patients for 5 months or 25 years. I hope this helped. Again, please find us on our social media and on our website. The links will be embedded below. I will have some of the links to the studies that I alluded to, both on our website, as well as on our social media. Please tune in for more information on MDT. Coming here on out, you'll see more case studies as well as more information. Maybe that's a little bit controversial in our field right now. And I hope you enjoy this as much as I have. Move your patients early, move them often, and move them to end range, because that's where the magic happens. Thank you, and have a good day.